to get the message across that muscle biopsy has to be sent in a specific manner, because otherwise many times I'm sure we receive biopsies and then the pathologists are not able to help us with much because there are no clinical details or the muscle has been sent the wrong way around. Without much ado, because we have a whole load of clinical cases that we want to discuss, I just thought just to touch briefly on the clinical recognition of various, some of the common muscle disorders, which I'm sure most of you are familiar with, but I just thought it'll be good to highlight some of them because there are so many. And the common ones being the anterior hornsel disorders, the typical is the type 1s, which present early. I'm sure most of you are familiar with it. I won't go through the details. When we did look at the SMAs a few years ago, we found that about a good proportion of them, although we don't seem to achieve the numbers that internationally they quote, we had only, out of the 63, we had only 52 who had deletions of the telomere corpus. Interestingly, the NAIP ones, so the ones who had deletions in the neuronal apoptosis inhibitory proteins, appeared to be much more severe as compared to the ones who did not have them, but that numbers are so small that there is nothing much we can comment on it at this moment of time. We do have a number of cases who children who are not able to stand or walk, but have progressive scoliosis with spinal muscular atrophy type 2, and the milder ones of the spectrum of spinal muscular atrophy, where most of them are walking, but they're always wide base gait, ataxia with preponderance of weakness in the proximal muscles. They have a good chance of becoming wheelchair bound by early adulthood. The peripheral nerve disorders are very many, and again, the more you read about Charcot-Marie-Tooth disease and the more you understand the genetics of it, the more confused you become, because it seems to be so vast now. There's almost a gene cropping up every other day that at the end of the day you don't know what but to make it simple, the classic pes cavus deformities and the peripheral involvement are the suggestions, and you examine the mother or the parents because they are also invariably involved, or they're unaware of what exactly is going on. Professor Dubowitz actually mentioned that in one of the Lancet papers about the cows behind the number of genes being evaluated for Charcot-Marie-Tooth disease. The muscular dystrophies are very many. I won't touch upon Duchenne too much because we've had a lot of talks about Duchenne muscular dystrophy. Just wanted to highlight that in our own study, good proportion of them had no deletion, which was in keeping with probably what's seen in the rest of the world. Just been part of our international effort. We've actually published a paper recently in neurology. There are more coming. This is possible only through the UC Davis, Dr. Craig McDonald and his colleagues from California. We've been part of their natural history studies because, interestingly, although we know about Duchenne so much, there is very little data that is published in the literature about what really happens to these children, which proportion, how many of them get, let's say, get into respiratory involvement, at what ages do they happen, what about the bone densitometry? There was a lot of discussion about bone densitometry yesterday, and again, these are not clear, and which the genetic, is there a phenotype-genotype correlation at all? So we did, we've been following up with these kids over the last 9 years or so, and we hope to continue this with more grants coming at least for the next 20 years, and hopefully we will get more idea about what actually Duchenne muscular dystrophy is all about, and that will help us when we get into the treatment modalities, because many times when we get into treatment, we are not aware actually what really happens to the natural history of the disease, and is it part of the static phase of these illness. When we did look at a study bias looking at the in-frame versus out-of-frame, clearly the out-of-frame children who had out-of-frame deletions did not fare as well as the in-frame, and this is well known, nothing new about it, but this is part of our own efforts to look at Duchenne. Becker muscular dystrophy is pretty common in our country, and again, it's important that we identify these people early. As Dr. Gayatri already alluded to, sarcoglycanopathies are not uncommon in our country again, and many of the sarcoglycan children present very similar to Duchenne. They can occur in boys as well as girls. The prognosis is variable. There's not much of cardiac involvement, but the dystrophin is present, and sarcoglycans are invariably absent, like in this child. And alpha sarcoglycanopathy seems to be much more common as compared to the rest of the sarcoglycanopathies. And this young girl, wouldn't forget, because they came from the east of the country with a diagnosis of leukodystrophy, just because she was not able to walk at the age of 2.5 years, and somebody had done a scan and found white matter changes in her brain. And that's not uncommon, and nothing wrong with the doctor, just that he was not aware of other conditions. And then the clinical clue was the fact that she was having significant proximal muscle weakness, which then led to the diagnosis of Merosin-negative congenital muscular dystrophy. The Merosin is completely absent. So these children do have these white matter changes. And interestingly, we've got a good bunch of them. All of them, the white matter changes do not seem to progress. Unlike your leukodystrophies, they seem to persist. Although we haven't been doing yearly scans on all these kids, it's just that they're in the ones where we have done scans a few years down the line, we find that these white matter changes do not seem to change much over a period of time. And the good thing is they do well. I mean, this was the first slide was in 1999, and then 2005. She's still coming to me, and she's doing very well indeed. So over the last 13, 14 years, she's only kept improving, and she's attending normal school or regular school. So they do well as compared to the other children, although the white matter changes do remain. Facioscapulohumeral dystrophies are not uncommon, and they do cause as much problem as your other forms of muscular dystrophies for the child. And this is another interesting with the arthrogryposis, hypotonia, high CPKs has, I think, Professor Matthews yesterday did show some slides similar to this with the not much brain, poor gyri and sulcation in the brain. And as Dr. Gayatri said, FKRP mutations are important. I mean, the fucotin-related protein, we don't have the facilities as yet, but I'm sure if we do look for them, we would find more cases of Fukuyama type of muscular dystrophies in our country. Another not so uncommon, I mean, we have about half a dozen children with this condition. We have they present with difficulty in opening the mouth, pursed lips, myopathic facies, and a pretty muscular build in these children, and difficulty in climbing stairs. We did publish series a few years ago in the Turkish Journal of Neurology. They have this myotonic discharges and very thin osteopenia, and most of them, and Schwartz-Jampel syndrome is interesting because these children again appear to be quite static. And she's actually attending a normal school and doing better. What's interesting is the usual phenytoins and the carbamazepines that we tend to use in myotonic dystrophies do not appear to make a significant amount of difference to these children as compared to. So I think in spite or even with our treatment, she's still doing well. Thank you very much. And that's exactly what the parents said. She said the parents came and told me saying that, Doc, thank you very much. We did try your medicines, but it doesn't seem to make a difference. But they still come at least once in 6 months and show us once in a while. As far as the myopathies are concerned, we see the whole spectrum again, classically with the valgus deformity of the feet, normal CPKs and the myopathic patterns on the EMG. We have a good number of children who have BiPAP ventilation at home. I mean, this young lady, this was taken in 2005. She's actually in college now. All she does is uses the BiPAP at night to sleep comfortably, because otherwise she finds it difficult to lie down comfortably. When she came initially, because she lives well beyond Kadalur, somebody was saying, doctor, this won't work out, but thankfully enough, they are very good. The parents regularly, and the servicing is also very good of the machine. And they are, although they are not highly educated and not very wealthy, they're doing brilliantly with the BiPAP machine. So I think we should consider home ventilation, and these machines are becoming cheaper, and many of them have been provided by us free of cost from our MDA, and we will support any family who really cannot afford to buy the machine. We will be happy to support them to get the machine and have a comfort, because otherwise sleep becomes a problem. Early morning headache and vomiting becomes a problem in many of these children. This is another child with the vacuolated myopathies. And again, Pompe's is important to diagnose with the floppy child with the respiratory difficulties, and you can see the tracheostomy. Important to diagnose because there is a cure available. And again, good thing about India is, although enzyme replacement is expensive, we do have support from the WHO for these children. And anybody who requires, they do have to pay up initially a significant amount of money, but many of, at least a few of our patients are on enzyme replacement therapy. It's too early for me to comment on how, it's too early for me to say they are doing brilliantly, because I haven't seen too much of major clinical improvement, but they haven't deteriorated and they're doing very well. So I guess it's early days, certainly from my experience, because it's over the last 2-3 years that we've been doing this. But the Pompe's, since there is a cure, I think it is important that we diagnose it early, counsel the family, and get these kids involved. And certainly the earlier you get them involved into the enzyme replacement therapy, the better it'll be in the long term. Sphingomyelinase deficiency, although it does not come under neuromuscular disorders per se, I just thought it's important to highlight that there are other disorders which present with a floppy infant, and many of them, I know how many of you have seen cherry red spots. They're not that difficult to visualize, and they're important to pick up, because this gives us the diagnostic clue to know where we go for. And that is why clinical medicine is very important, because at the end of the day, the diagnosis lies with what we are able to identify clinically, much more than from our diagnostic tests. We do the other whole group of disorders that we see is like this young lady who was 18 years at the time. I saw her in 2004. She had leg cramps while walking, stressed. At 7 years, had hand tremor during piano classes. Then she started deteriorating by about 10, and where she was dropping things, worsening coordination, difficulty walking and climbing stairs. And what's dramatic about her is this MRI that she had in Singapore in 1999, and what we saw in 2004, progressive shrinkage in the brain, and of course the few EEG changes suggesting that she was actually getting these jerks, what appeared like myoclonic jerks. Her ERG showed pretty much a flat pattern, suggesting that there was involvement of the eyes, the brain, as well as obviously the weakness was progressing. The SDH aggregation, the NADH-TR aggregation, confirmed that she did have a mitochondrial disorder, and many of them present with features of muscle weakness, because that's what is obvious to the family, rather than actually the rest of the subtle findings. Myasthenia, again, is not uncommon. And what's interesting is congenital myasthenic syndromes are pretty much common. It's just unfortunate we don't have facilities for looking at it in a deeper, and I don't know whether Dr. Gayatri can help us with exploring the idea of looking at the neuromuscular junction in a little more detail, because we do have a good number of cases of children with congenital myasthenic syndromes presenting with very early onset ptosis and poor eye movement as well. And some of them do respond better with neostigmine, or we did look at the genes of these children. This was part of our CMS patients. The 1267 del-G mutation was strongly positive in our population. Interestingly, this was quite different from the CMS mutations they had in Europe. And Hans, my collaborator, was pretty much surprised when we did look at the whole thing. And he was saying, Vish, this is very interesting, because from where we started, although we started with a straightforward study, we realized that the gypsy population had migrated from India many years ago. So it led to some founder effect, and a completely different story from there. But this is something that we need to look at in more detail. There are other neuromuscular disorders, particularly dermatomyositis and polymyositis, not uncommon in our country. And again, something that if picked up early and treated appropriately, they do much better. And therefore, one needs to look for these clinical clues, Gorton's papules. If otherwise, we could miss them and we end up not diagnosing them. I know, again, hypothyroidism is not a neuromuscular disorder, but I just wanted to highlight that we still seem to see it because we don't have the neonatal screening as much as we would like it to happen, and therefore we do now and again have floppy infants presenting with in our OPDs. So do consider that as a possibility, something eminently treatable, and the kids do well. And this young man, when he came to us, had with severe respiratory difficulties, had a huge PCO2 of 89.7, bicarbonate of 37.4, so suggesting that he's had chronic lung issues, although interestingly, he did not decompensate until the time he presented to us, which was interesting because many of these kids are not that good, and he has got these straight back with the wasting of the muscles, both at the back, scapular, humeral, and peroneal groups of muscles. I haven't shown you the peroneal group, but he had wasting all over. And this whole alert-looking boy had features to suggest that He had severe restrictive lung disease as well. So with that combination of the scapulohumeral peroneal wasting and the severe restrictive lung disease, this was the more likely diagnosis of Emery-Dreifuss muscular dystrophy, usually present during adolescence, and they do have contractures, which this boy had. So contractures of the ankles and the elbows, the scapulohumeral peroneal wasting, severe restrictive lung disease, and pretty much a normal intellect would did suggest that he had Emery-Dreifuss muscular dystrophy. His brother's CPK was 380. This is the young man with the myopathic facies and the partial ptosis and the proximal muscle weakness and the cardiomyopathy. We did look at his gene locus because I was interested in the laminopathies, and he did have a mutation in this area. But again, if we look for it, I think we will find it as the answer. But we need to keep looking for these disorders, because there are plenty of these neuromuscular disorders in our country with over a billion population. I can keep on going because we have a huge list, but I think that we have 3 or 4 interesting cases. So I would hope to stop. I mean, these disorders, Ehlers-Danlos, and disorders similar to that, are very common again in our country. The clinical varieties are huge. Pursuing a clear diagnosis is not academic. That's, again, many times I'm told by doctors and professional colleagues of mine saying, no, this genetic testing is purely academic. Why would you want to biopsy him or do a gene test? It helps counseling. It helps prenatal diagnosis. It's helpful in prevention of these disorders. And that's the goal, is to try and prevent the recurrence in the same family or their sisters, children, etc. And although there are therapeutic options, a few, but there is it's important to consider there are huge genetic variables and the explosion of knowledge, explosion of number of researchers in this field. And as Satish, Dr. Khadilkar said yesterday, we're all in it together, and it's time that we start networking within ourselves, and we will do it, is the answer, because we are making the initial efforts to do that. We are part of a global initiative to find solace to the families of children with Duchenne and other neuromuscular disorders. I work closely with the Treat NMD and the Synergy, which is a cooperative international neuromuscular research group from Washington. Our sincere thanks to many people, because they have been with us, particularly my physio, Mr. Suresh, and of course my huge number of colleagues of mine who've been volunteering for our MDA clinics. We do have our website here. I'm also thankful to Apollo Hospitals for permitting us and providing us the services and the space for doing our studies. And without that support and without that help, we could never establish research facilities at Chennai. Thank you all, and